We're pleased that you joined this webinar, and I'd now like to introduce Meeta Gandhi, who currently serves as the co-director of social work and counseling with Student Support Services at KIPP, New York City. She has over 15 years of experience as a social worker and program director for child and adolescent mental health services in community psychiatry. And during that tenure, she co-piloted New York City's first children's mobile crisis team with the Department of Mental Health and Mental Health, and through this project became interested about providing services to children, adolescents, and their families in their school communities. Meeta, I will turn it over to you.
Thank you, Dana. And I'm so pleased to be here. As Dana mentioned in the introduction, part of the reason I was so excited to be included in this team's idea for this was that it was really my experience with piloting the Children's Mobile Crisis Team that led me to my current role as working for a charter school network, because I felt like so much of the work in the pilot program sort of led me to thinking about how we can build capacities in schools. So this is really a passion project of mine. And I just want to name that my experience with the program was really in its first 2 years. I was the director of the program. We did have a program coordinator. And so as we spend this time together, just really wanted to focus on the implementation phase and the kind of the pilot phase of it and the lessons learned through that initial stage. So just wanted to ground ourselves in the context of sort of where I'm speaking of it. It's a very thriving program, still currently doing very well, but just wanted to talk about sort of that implementation phase. I thought one of the things that might be useful for us to think about was the ways in which, when we were thinking about the program, where we really invested and emphasized in sort of the research design aspects with the hope that it would be as successful as possible. And what I've listed here are what I thought were some of the advantages and some of the disadvantages. I think one big advantage that we had that I wanted to highlight is that we had true partnership with the funders. And because we were working so closely with DOH, MH, they were able to provide us with introductions to so many important stakeholders. And that included protective services, ACS, school mental health services, and the school-based programs, as well as the DOE. And ample meetings with these focus groups allowed for us to really be thinking through what would allow for the most seamless and most accessible program possible for both schools and families. We also were able to consult and do intervisitation with other programs, including New Jersey. One disadvantage, or a couple disadvantages, was that we were starting off small. It was a pilot program, so there were budgeting parameters that only allowed us to serve the highest risk Bronx districts in phase one. Since then, it's certainly expanded to Queens and Brooklyn, which I'll talk about. But in terms of like reaching the highest group of people, but with sort of a small pilot group, that was a disadvantage. And I think to some extent we had, although ample focus groups with other stakeholders, the focus groups with students and families were not as sufficient as I would have liked. And I will be talking a little bit about that, about what I think were the drivers that led to that insufficiency. And as I thought about our time together, I thought I would separate it into sort of 3 chapters, so to speak, in thinking about access and program access, the staffing model, and also the services that we provided. So in terms of access, we really promoted ourselves as we were a psychiatric alternative, a non-traumatic psychiatric alternative to hospitalization. We were going to be operating 24/7, 7 days a week, to provide rapid response within 2 hours. So if a call was placed to us by a family or school, our commitment was to respond within 2 hours. We were servicing these districts. We wanted to be able to serve 0 to 18 years. We were going to be leveraging a centralized referral system. So we were not going to be accepting referrals individually from schools and families, but we really wanted to operate within a centralized referral system. And we were committed to a staffing model that included an LMSW and a family advocate, with the idea that after the initial visit, when we first responded to the crisis, whether it was at school or at a home, we wanted to be able to provide 1 to 4 follow-up visits, where the LMSW and the family advocate would actually continue that care with the family. And so we were trying to, again, try to provide as wide of access as possible as we thought about the model. In terms of staffing, we started off small. We had 2 full-time LMSWs and 2 full-time family advocates. It was very important to us that we hired people with persons with lived experience. As I mentioned, we had one program coordinator, and then I was the point 5 program director. We defined what the primary roles for the MSW were going to be in the family advocate. And you can see here, we sort of tried to highlight some of the key responsibilities. It's going to conduct a safety assessment and a plan, and really develop a relapse prevention plan and work with the family around what went into de-escalating the crisis and what could work next time. That was important to us in terms of capacity building. And in terms of the family advocate, we really wanted that person's role to destigmatize mental health and access to mental health services, provide psychoeducation, and certainly any advocacy in those 4 follow-up visits. I listed here some of the services. We obviously had the assessment, the stabilization of the crisis itself, the prevention planning piece, and then continued caregiver support. And I just wanted us to keep in mind that it was really, the idea was to be able to provide those services to families in their homes if they should be calling the centralized referral service directly, or to schools. And you'll see a little bit later about the data we got in year 1. In terms of the services of what we could do and what we couldn't do, we really wanted to clearly differentiate to the schools and the stakeholders about where our limitations were and where we really had freedom to be able to work under. So I just have a list here of what we were able to do. Thank you, Dana. And just to highlight here that some of the difficulty that we had when we met with the stakeholders were really around some of the can't do. So it was really important in those stakeholder focus groups to sort of spend some time on like why we couldn't. So for instance, escorting a child to a hospital was a big one because that was something that schools and families were really used to, particularly schools. But that was going to be something that was going to distract from our ability to be able to respond to another crisis if a call should come in within that 2 hours. Another one where we spent a lot of time managing expectations with our partners were around the follow-up visits with and without consent. Schools wanted to be able to have the ability to be able to call our crisis team, even if they weren't able to get in touch with the caregiver to be able to provide that consent. So where we settled on that was that they were going to be able to call and attempt to make contact through a voicemail message. If they got the family in person, that would be great to provide that consent, but that consent should not hinge or thwart our ability to be able to respond to the crisis. But certainly if we were going to support the family for 4 visits moving forward, because we were going to be working more closely with the family and entering the family's home, we needed that consent. So if a family did or did not consent to the initial crisis response and then chose not to consent to our continued services, we respected that right and we did not continue those follow-up visits. In terms of the implementation design, we did spend a lot of time on norming on the word suicide and the intent behind it and what that meant, because again, we had schools that were very used to calling the ambulance or calling the police. And so we wanted to differentiate that if this was a crisis that could tolerate the threshold for the 2-hour response time, that was the sort of situation in which they would need to call us. But if there was something imminent in terms of risk, that we wanted them to be able to continue to have the right to call for the hospital and the ambulance in the way that they were used to. We did spend a lot of time on the centralized referral service because we did not want time to be distracted from our 2-hour response time. By the time that it took for someone to make the referral was going to detract from the 2-hour response time. So we needed that to be as streamlined as possible. As I mentioned earlier, we spent some time on the guardian consent piece. And we also provided our staff with a tremendous amount of training, which I'll speak to a little bit later. Motivational interviewing, which is MI, CPI, which is crisis prevention intervention, the CANS tool, which is the Child Adolescent Needs and Strengths Assessment tool, and also the family advocates received peer-to-peer training through Families Together and family peer advocate models. We really invested heavily in family advocates with being very clear that we wanted persons who had lived experience and training. we had a proactive arrangement with our central referral partnership. And what that meant was essentially we had, after the sort of program startup piece, we continued to have monthly meetings, actually bi-weekly to start, and then we moved to monthly, where we continued to talk with them about where we were encountering issues, to troubleshoot them and to correct them. So we were able to do that in real time with 1-800-LIFE-NET. We continued with the management of expectations regarding consent. And what was really lovely about the model and so effective was that the rapid and mobile response really allowed for real-time coaching in the here and now in de-escalating the crisis with a student, particularly on school premises. The motivational interviewing allowed for enhanced partnership, and that motivational interviewing really was partnership with schools and school personnel, because we know that time is short. Their energies are really dedicated to classroom management and more macro. And so that allowed for partnership with schools as well as for families. One thing I think we did really well is that we leveraged the enormous amount of community programs that we had. So if we had respite programs that we could make connections with, faith-based organizations, medical clinics, we had a borough-based family resource center in each borough, and also resources for children with special needs. And the idea is that as we thought about the warm handoff for the family after we sort of left after the 4 visits, or even if they had not wanted to consent to our continued 4 visits, that we had places that we could continue to link the families to. And I think we paid a lot of attention to that. And we were lucky in that we had a lot of community organizations we could do those linkages with. And as I mentioned, the Child and Adolescent Needs and Strengths tool allowed for strength-based assessment. If people are not familiar with that tool really allows for us to evaluate where are the strengths and the protective factors in a student's environment that can include the school. And so with that, we were able to leverage those strengths too in a family. This gives a snapshot to year 1 data. And I'd just like to highlight here a couple things that really stand out, which is that 62% reported as exhibiting aggressive behavior. But the primary diagnoses actually of those students were ADHD, attention deficit and hyperactivity disorder, as well as mood disorders. 66% had never been in prior mental health treatment. And I have to say the program was able to respond within 2 hours for 100%. One interesting anecdote was that 67% of the families who called, whether it was a family-directed call or a school-directed call for a family or student, had previous or current ACS involvement. And that really began to sort of help us serve the purpose of like who we also needed to continue to have relationships with. So if ACS was something we needed to work hard at because those families had had previous or current relationships with ACS, then that sort of directed where we could continue to invest. I think our investments worked. The Bronx team served 175 total, 12 were hospitalized out of that 175 with only 2 repeat students. And what this really suggested to us is that in that year 1, and I think it's just continued, we were really able to make sustainable change through meaningful engagement with the idea that really only 12 of those were legitimate hospitalizations. So in a way, the rapid response model was really effective in terms of servicing the other kids. There were some lessons learned as we've sort of been talking about throughout our time together. I think we were doing a good job in sort of psychoeducation with schools and families about how to actually use our program. The consent for the follow-up was difficult, and that was something we continued to try to tackle. And it was difficult to get survey feedback results from families post-service. So what that meant was we really wanted to be able to send surveys to the families to say, like, what was effective about the program, what was not effective about the program, because we were really looking to see what would tweak. And it was difficult after they were done with us. They really was sort of hard to get that survey results. We had some ideas about it. We did find that families called us sort of a couple months later, just wanting to like a reminder of like who they could contact for a certain connection or a linkage. So we thought it might be helpful instead of the 4 post follow-ups to just sort of provide what we were calling a booster shot, which is a one-time call just to see how families were doing. And that was something we did try. From a staffing perspective, our family advocates were key. And from a services perspective, I think what we were finding is that there was really effective opportunities for effective repair work between families and schools. And what I think I mean by that is that families, to some extent, had been burned in a way by sort of their kids being sent to the hospital, perhaps really unnecessarily, because if it wasn't for a psychiatric issue, it was really for a behavioral issue. And so there was some repair work to be done. And I think us being a conduit for the family in terms of the family advocate and the LMSW was really helpful with that. There was certainly capacity building for CPI or TCI, therapeutic crisis intervention in schools. And again, we just continued with the management of expectations regarding our escort of the students to hospitals. This is just a snapshot of year 1 to year 2. We can see here that we had more referrals coming from family or caregivers and 16% from other sources. So word was getting around and a lot of other places were calling us, which was great. For that year 1 to year 2, we did create a crisis coordinator, and that was really only for the Bronx because again, we had a small staffing model, but we wanted that crisis coordinator to be able to serve as more of a conduit instead of the family advocate for schools. And then we still had the 3 social workers and 3 family advocates. And we were a lot more heavy in terms of being able to service 0 to 5-year-olds because we were getting more calls from families. And this is a snapshot of kind of where we are now. It's thriving, I'm so happy to say and happy to share. We are servicing the full borough of the Bronx, Brooklyn, and Queens. We've served a total of 503. We still see here a very low number in terms of psychiatric admissions. I believe in the course of the last few years, they did eliminate the crisis coordinator and felt that a lot of that capacity building could still continue with the social workers and the family advocate. And we moved our centralized referral from 1-800-LifeNet to 1-800 and NYC Well, which is still going very well. And so as a group who might be interested in this, either participating or implementing such a model, I think just certain things to consider would be your community linkages, because that's going to really help with the capacity building from a community perspective, how you might think about feedback surveys from consumers, paying special mind to your referral system. One thing we didn't do was really how to engage police departments. I think that was a missed opportunity. That brings up mixed feelings. There are mixed considerations about that. But given the fact that it is a system that is typically engaged in a school at times during crisis, it might be worth considering, and certainly how you're going to be building the capacity for schools to identify the evolution of a crisis before reaching to having to call a mobile crisis team. And that is it. Thank you so much. And I'm so looking forward to hearing any questions people might have.
Thank you, everyone. I'm Martha Staley. I'm the director of the Childhood Trauma Learning Collaborative up here in New England for the MHTTC. And thank you so much, Meeta, for talking to us about this. Really inspirational, and it sounds like a very thoughtful and compassionate model to help support children and families who have experienced these types of crises. It sounds like you have quite a bit of success to be very proud of. And I have a number of questions for you, but we did get a question in the chat, which I will ask you first. Tide Services asked, I was wondering what the average length of time was for youth to be involved with mobile crisis. So how quickly did that youth move through the program of, I'm assuming the initial crisis to the 4 follow-up visits?
That's a great question. It was 4 follow-up visits or a month, whichever came first. So our average sort of a length of stay was a month's time, and we would try to do 4 visits in that time, continue visits with the family. We were not rigid about it, certainly at the beginning, because we really wanted to make sure that we were understanding what the presenting issues were with the family and make sure we sort of addressed them in a sensitive manner. So we were not rigid about that. But in terms of an average length of stay, I would say that typically families stayed with us kind of between the 2nd and the 3rd visit, what the cycle we were finding is that they were sort of with us for between the second and third visit and kind of would drop off. And then about a month later, call us and just ask us for like some booster shot support, which we always provided.
That's really interesting. That was one of the questions I was going to ask you, is how you arrived at the 4 visits and whether that was born out of sort of your qualitative experience doing this work and finding that was the length of time for these sorts of intensive services that was the most useful to families. But that's really interesting that the intensive 2 to 3 visits really, it sounds like, got people rooted on the next part of the path. And then this idea of a booster shot, I think, is a really interesting one, that follow-up visit to just check in. And I'm assuming just check in with them and ask, how are you doing? And what do you need now? And I don't know if you were able to collect any data about the results of that booster shot. Did you notice any patterns in that?
We noticed, yeah, that's a good question. I mean, I think there was certainly research to suggest that sort of a 2 to 4 visit was ideal. And the second thing was that it was really the parameters of staffing. We wanted to be able to continue to provide access for the rest of the programming, but like we had limited staff and they needed to be available. So we couldn't sort of stay with a family too long. The booster shot, what we were finding is that, relationships had been built to some extent. And because the family advocate, and we were now effectively being seen as a conduit for the school, we were being leveraged in that way sort of some time later. So they were utilizing us to just, make sure that we were still there, I think, primarily and largely, and that we would be available to the school and available to them. And a lot of it was just also information seeking, ensuring that like the information we had given to them, which during the time of the sort of the crisis, maybe wasn't going to be retained, but now they were sort of ready to think about it and come back to it and really sort of leverage that. So that was sort of what we were finding was the best use of the booster shot.
That makes a lot of sense about there are things that children and families and schools can absorb, and what is what they're attending to in the midst of the crisis, and then these different stages of recovering and finding their footing again afterwards. But you brought up just the 3 different overarching topics of the program: the access, the staffing, and the servicing. And obviously running a program like this, or establishing a program like this, is so complex, particularly in an area like New York City with different boroughs and different cultures and populations. So I imagine that they're finding that balance in those 3 overarching topics was really difficult. And I wonder if you could talk a little bit about the tension between those elements of your program.
Yep, absolutely. I think the largest tension we probably felt squeezed between was really around the access and the staffing. Like I've mentioned a couple of times, it being a pilot program and a small staff, but also wanting to be available and accessible to anyone who should call, because we were also just frankly trying to get the word out there and really believed in this and wanted kids and families to have the opportunity to have a non-traumatic option, and schools certainly too. I think how we sort of navigated that was just really, again, like so many positive things to say about sort of the family engagement piece through the staffing model of the family advocate and the LMSW, because families are experts at what helps their children on an individual in terms of de-escalating them at home. And there's a lot of transferable skills in terms of what works at home and what works at school. And because schools and teachers are under such enormous pressure to sort of manage a classroom and manage a whole group of kids, understanding or developing the capacity to understand what works individually for each student can be hard, and they don't always have the time. So to be able to be that bridge where we could engage in the family in an effective way about what was most effective with their students, and then transfer those skills and that understanding and that knowledge to schools, so they almost had like a crib cheat sheet on like, for this student, this has worked most effectively at home. If you think about it from a student perspective, that transition between what is working at home to then be applicable at school provides such a grounding, trauma conscious perspective as well. And so that aspect of highlighting the family engagement piece was really what allowed us to navigate some of that difficulty with that tension between those two aspects. I don't know if that answers your question.
It does. I mean, I would say I have a lot of questions about the family engagement piece because we know that engaging families, supporting families, particularly when they are facing trauma and crises of the type that you're discussing, is so critical and so important. And I appreciate you framing families instead of well, systems often have the perspective that families are impediments, right, to getting to the next piece of the whatever the process is for children. And I really appreciate you framing the families as the experts in what works well for kids and what the strengths are of the families. But I know that engaging families is really challenging. So I wonder if you could talk a little bit more about how you engaged families in this program to do that tough work.
Yep. Well, I think that's absolutely right. I think a school system is a system, and for families who have also had disruptive experiences with systems in life experience, and then certainly with schools, you sort of see an aggravated response on both ends. And I can really understand why there's this feeling and this disconnect. So entering into a family's home was sort of an equalizer in a lot of ways, because we were being invited into their home to basically try and support them in terms of what was happening at home. So that level of equalization really, I think, facilitated a family engagement aspect that we couldn't even quantify. We also, as I had mentioned, sort of talked a little bit about the motivational interviewing and the CANS assessment. And the motivational interviewing, because it really allows, again, for an equalizer in terms of us not being experts as we entered into the family's home, but really being around holders of space to sort of outline what's possible in terms of change, and really allowing for families to partner with us about what they felt capable of doing and what they did not feel capable of doing. And so that allowed for true partnership around managing expectations about what change was possible right now. And then it just brought them a lot of peace of mind to know that we were going to be giving all this information. It was actually our job to give this information to the schools in a way, hopefully, that, that they trusted. And then in that month's time, if we could bridge the connection, then families and schools were actually communicating a lot more and a lot more effectively. The CANS tool also, I just can't emphasize enough sort of the idea that trauma, when we think about trauma, is not an individual state of being. It is an individual experience, but it is often created by a goodness of fit or a lack of goodness of fit in terms of individual and their environment. And it's something that's often has happened to someone. And so when we think about sort of amplifying or elevating the strengths and the protective factors of a family, elevating and amplifying what they bring to the table, and then highlighting that for the school, I think that bridged a lot of feeling of the family was not just being resistant, but that there were actually certain environmental issues that were impeding and then sort of helping the school see that they could actually really be a protective factor too by being trauma conscious or by being aware of what some of the limitations were. So it just the whole language we were using, I think, was a way to really promote some of that.
Thank you for that. And that really brings to mind some of the questions that come up so often in this work about being responsive to people's culture. And I imagine that in a place as diverse as New York City, there are a lot of cultural considerations that are important, as well as some really practical challenges around, I would imagine, language or things like that. So I wonder if you could talk a little bit about what kinds of considerations you had, maybe programmatically, in terms of addressing and being responsive to culture
Mhm,
and
mhm,
equity issues?
mhm. That's a great question. Our LMSWs and family advocates were all bilingual. So that was one sort of immediate consideration we tried to have in place. And then we did a lot of work in terms of talking about being trauma conscious, and I use that word very deliberately. I don't use the word trauma sensitive or trauma, because what I wanted a staff to realize is that being sensitive to someone's trauma is not enough, that actually as individuals, as part of an authoritative system, we have the capacity to actually activate and engage that trauma, so that we have to be conscious of it in terms of what we are bringing to the table. So we actually spent some time also looking at doing anti-bias training and the biases that you have when you come in and you ask an open-ended question. Certainly the motivational interviewing training supported that as well, because the two blended really well. And I think, I sort of hadn't thought about this until now, but as we continue to work with the families, the relationship allowed for them to also provide some checks and balances for us in terms of where they felt like maybe we hadn't been considerate or where we needed to be more considerate. So they were in turn also building the capacity for our own staff to be sure to be sensitive to that. But as I mentioned, sort of some of that training stuff and some of the anti-bias training, as well as the linguistic sensitivities we tried to have with our staffing model, tried to take that into account.
Yeah, it sounds like you really thought of those families as sort of as partners, as collaborative partners, sort of co-building this, the next steps in this support system. And we have a couple of really good questions that I'm going to get to, but I wanted to talk about a different partner, a different collaborator in this this system, this program, and that is the role of the schools and the folks that called you in to address some of these crises. And we have another colleague, PJ Winger, who from our sister network in the Northeast, who mentioned that when she was in schools doing this work, she often found that schools would call mobile crisis teams towards the end of the day, right when that 2-hour window gets really tight and difficult. So I'm wondering about how schools might be able to do some of that work earlier in the day or earlier maybe in this cycle to either reduce the number of times that you're called or to help facilitate a non-traumatic intervention.
Definitely. I think to some extent, I looked to the data around that we had in that first year, where we had 175 calls and 12 were hospitalized and 2 were repeat. And in there, I think that speaks volumes regarding sort of the differentiation, I think sort of the differentiation between a psychiatric crisis and a behavioral crisis. And so if only 12 were hospitalized, to some extent that speaks to what were true psychiatric, legitimate required hospitalizations and what were not. And so then if I think within the domain of a behavioral crisis, using kind of the crisis prevention intervention arc or evolution of a crisis was such a lovely way for us to think about it. And I think provides a lot of information there, because if we, people are familiar with it or not familiar with it, there's sort of 4 stages. There's sort of the anxious stage, where when it has to be supportive. And then there's the defensive stage, which requires another set of interventions. And then there's the actual risk behavior or crisis. And then there's sort of after the crisis where you're sort of establishing or reestablishing therapeutic support. And so much is happening for the students or for the kids in that sort of first 2 stages, the anxious stage and the defensive stage. And when you think of antecedents, sort of things and sort of triggering or activating factors in a child's environment that's sort of causing that anxiety, what we were able to do is we were able to sort of facilitate a conversation about, this is how this child or student looks anxious at home. Is this behavior that you're seeing at school? And if so, what are some tier 1 interventions you can have in your classroom to sort of help universally all kids, but then certainly this child. And so I think we spent a lot of time in that capacity building with those first 2 stages. And with that, I think when we see the statistic of we only had 2 repeat students, what that suggested to me is that we had no repeat calls on a student, because hopefully, and maybe this is just hopeful thinking on my part, but that schools at that point had been able to identify and anticipate when a crisis before it was going to evolve and sort of get in there in terms of prevention.
Thank you. And I'm wondering, because those statistics are so impressive. And I think, I really think about your point about if only 12 kids were hospitalized psychiatrically out of all of those, it really tells you, I think differentiating between the behavioral and psychiatric crises is really, really important and valuable. I'm wondering if you got feedback from the schools about this program, either from individual people at the schools or how they viewed this particular team in managing those crises.
Yeah, we don't, I don't recall that we had formal surveys to them, because it was often like, people just didn't have the time and the bandwidth to be able to, but anecdotally we heard positive. Yeah, anecdotally we did hear positive, there was generally a positive feeling towards the efficacy of the program, but also just generally feeling like they were just so happy that they could call somebody, and because they were not happy about having to send their child to the hospital. We had set up, sort of as a society, such a binary kind of model that it was like in the school or out of the school at the hospital. So they really felt so hopeful about the fact that there was this alternative.
Thank you. And now I'm going to switch over to some of the questions that we're getting in the chat. And please, others of you, if you have any questions for Meeta about this, we would love to have her answer them. But I'll start with Sue Mullane asked, what benefits and funding opportunities for the future would you hope for this network and partnership?
Yeah, that's great. I think that certainly maybe funding from the DOE too, that might have been helpful, because in some ways, we're not just servicing we're not just servicing charter schools, we're not servicing private schools, we are servicing all public schools. And given the fact that in some ways there's an alleviation of their own internal resources, I think that might be actually a wonderful opportunity to continue to look at. And as I said, sort of maybe the police department as well, in terms of rerouting funding in terms of the resources that are used when they have to escort a psychiatric student, somebody who is in psychiatric crisis, to the hospital. That might be another funding source as well. It's a good question. Thank you.
I know that in New Haven, the police have spent quite a bit of time trying to work with mobile crisis units, particularly among the adult population, but because of the tensions and the often people are just not prepared, don't know what to do next to support people that they are who are either having a behavioral crisis or a psychiatric crisis.
Yeah.
And so here's another question from Tide Services about the youth connection, the service connection of the youth who were using mobile crisis. Were they generally able to be connected throughout that mobile crisis? It looked like not everybody had already established service relationships or mental health professional relationships prior to these crises, but were you able to make connections?
Mm-hmm. Definitely. I think the two most utilized linkages that we were effectively able to connect families to were respite services, in terms of caregiver support and respite for the caregiver, as well as mental health services. As you may recall, the data point was around how many students had not been connected to prior mental health treatment, but sort of being able to be connected to mental health treatment was an important linkage. And one, we had a lot of mental health providers, a lot of CBOs, and there are a lot of CBOs in the Bronx, and there are also long wait lists. So one sort of access to that service was the idea that like there were, in terms of wait lists, but because we were a mobile crisis team, in some ways we took the place of what used to be called, like when a hospital made a discharge and we had to, I used to work for a community-based organization, we had to provide an appointment between 0 and 5 days. So in that way, the CBOs had to provide an appointment to our families within 0 to 5 days. So we were able to sort of circumvent that, which was really wonderful. So in that sense, all families and students were able to stay effectively connected to continuing mental health treatment.
Yeah, that window of time is just so critical and so challenging, often to ask people to try to figure out how to access support when they're also managing such an acutely difficult crisis. Let's see, we have a couple of other questions about, this is something, I'm not sure if this was after your tenure in this program, but it's about providing in-person services or mobile crisis services during the pandemic.
Mm-hmm. Yeah, I'm happy to speak. I'm still very good friends with my colleagues.
Oh,
and because I'm working for a school network now, we also needed to know if they were still continuing to provide services, because now I'm on the other side of it. And because schools, if they were not in session, mobile crisis was not providing services. But for families calling directly for services in their home, they did continue to provide the service during the pandemic, because now the need was more, in some ways, more than ever.
Yeah, there are so many questions about how to deliver those and how to provide those kinds of services in the midst of the pandemic and COVID, which is obviously a really challenging issue.
They might have amended, meaning doing more of a phone assessment initially to distinguish whether or not actually a visit to the home was critical, and may have triaged over the phone. And then I think they suspended the up to 4 visits, because certainly that was going to be an exposure that was not going to be safe for anybody. But they were responsive to crises and did not discontinue any of those services.
And obviously that's such a concern now, as we are realizing that the kinds of traumas that kids are experiencing over the last year are so widespread and incredibly difficult for so many kids and families. So obviously that's an issue that's going to be ongoing. Let's see, we have about 10 more minutes of questions. If any of the rest of you in the group have other questions for Meeta. And if you don't, I certainly do have quite a few more questions. So I'm wondering about, like, and this can sort of relate to the delivering services in a pandemic or under really challenging circumstances. It sounds like your staff really had quite a lot of training to be able to do this. Now that you're working more in the school system, what types of training do you think could be or should be provided to school staff to help them address some of the mental health crises that we're seeing now and likely to see as we move into the next phase of this pandemic recovery response?
Great. That's great. I think about that a lot. And I think the first would really be around CPI and sort of an identification and an understanding of the arc of and the evolution of a crisis, where schools can really spend and staff can really spend time. Really the hardest distinction, I think, is between defensive and crisis, because very defensive behavior, if we define it as sort of the beginning loss of rationality, can move quickly into then a total loss of rationality, which is what really defines the difference between defensive and crisis. And so that gray area, I think, is a really helpful space to sort of live in and be in as a school staff, in terms of for each individual student, what is defensive behavior that is beginning actually to look like a crisis to us, but really isn't. And, working in a school system, space is limited. If staff, and I think about, certainly to the participants' question around the pandemic, we're all in a collective trauma experience, and there's a lot of hypervigilance. And so if as a staff person, I am identifying something as a crisis that really isn't, and I take that child and I put them in a room, and then you have 6 adults sort of crowding the kid and trying to de-escalate, that in of itself becomes an enabling system to sort of escalating the crisis. So if I can really live in that sort of that difference and distinguish it, I think that's really helpful. So CPI certainly. And then to whatever extent people are receiving training on being trauma conscious or trauma responsive, what are the elements of how trauma can manifest in the classroom, reflecting certainly on our own trauma and stress responses and how that can actually facilitate a decrease in crisis or enable it. I think there's a lot of benefits to sort of staff having the time and the space and the bandwidth and the permission, the organizational permission to spend some time thinking about that.
That's incredibly helpful, very concrete ideas, and something that, we are often hearing in the C-TLC and in our work is school staff or mental health staff not feeling like they have the time, and they're experiencing burnout and having a difficult time reflecting on their own trauma and their own experiences during this last year. But I am thinking about the role of the family advocate with lived experience on that team. And I wonder if you could just talk a little bit about how having somebody with that lived experience was helpful to your team. And I'm assuming it's lived experience. Was it lived experience with their own experience of a mental health issue,
Yeah.
or was it lived experience of being a family member or a parent?
Yeah, it was, that's a good question. It was around persons having a lived experience with mental health issues themselves. They could have also had family members that had mental health issues, but we really wanted that person to have lived mental health experience who had experienced navigating multiple systems. And so that they could help be the conduit for the family to be able to do that to receiving systems. And we also, didn't want them with that lived experience, sort of allowing for a space where they're not coming in as an expert at, as it is the LMSW was being, they had a credential, they were coming into a person's home. There's lots of authority sort of associated with that, but with a lived experience and the experience of having navigated systems became an equalizer in terms of them not being an authority in that way, and really facilitated sort of the destigmatizing of mental health because they themselves had that experience.
Yeah, I mean, with that lived experience piece, you get the destigmatization, but also that element of compassion and humanness, and I think the framing around the lived experience around navigating multiple systems is a really helpful frame for when people in a school system or others out in the community are thinking about that lived experience and ways that they can incorporate that into their own work, is thinking about navigating systems, managing crises, loving somebody in crisis, and sort of that systemic approach to supporting families and children who are dealing with this. We just have a couple more minutes. Are there any other questions from our audience?
Thank you all so much for your thoughtful questions.
Thank you so much for presenting the work that you're doing, and with so much thoughtfulness, with so much heart. And I'm wondering if you have any final thoughts about people. I know we have people from Maine or throughout New England or different areas that don't have a mobile crisis team of this sort. If you have any, I guess, parting words of wisdom or advice for people who are looking to build this sort of team in their own communities.
I think, yes, I think without a mobile crisis team, there's still so much of the program's efficacy really was what lent itself to sort of working with the schools. And I think that work can happen regardless, whether it's through family members or community members, et cetera, in terms of, again, that crisis. And it's interesting because one final thought I have is sort of around the pandemic, and I think this is a really interesting time to think about all of this, is that I wonder if one silver lining to it is that there's going to be a truer partnership between families and schools, in some ways, which function without the mobile crisis team, to a large extent, because the mobile crisis team has not been responding to behavioral crises at home as much. They've been responding to psychiatric crises. And so I think as families have built their own capacity about understanding from a teacher perspective what it's like to manage their child's schoolwork at home, along with all the other behavior challenges or behavior manifestations of it, there's just I think maybe perhaps a more compassionate understanding on both ends about what it means, because we've been in similar experiences, whether it's sitting at the school or sitting at home. And so I wonder if in some ways people will return with sort of a newfound shared experience in that way too, with the kids having been at home.
I think that's a wonderful way to end our time together on that hopeful and positive note. And so I just want to thank you so much for taking the time to tell us about your experience and provide some inspiration for those of us who are doing really difficult work in challenging times.
Thank you
to
so
help
much,
support
Martha.
the mental health of kids. Thank you very much. Dana,
Thank you.
You want to close us out?
Yes, thank you so much, Meeta, for joining us today. And here's Meeta's contact information if you have any follow-up questions about her presentation. Thank you, everyone, for joining us for today's webinar. Our funding does come from the Substance Abuse and Mental Health Services Administration, which does require us to evaluate our services. If you provided your email address during registration, you will receive a very brief evaluation survey about 24 hours after the close of today's event, along with our slide presentation and a link to request a participation certificate. We really do appreciate your honest and anonymous feedback. It helps us provide information to SAMHSA and assist us in planning future meetings and programs. We hope that you'll make plans to participate in upcoming online activities presented as a part of the Childhood Trauma Learning Collaborative. Please stay tuned to our website for upcoming events. We hope to have one on with Exhale to Inhale, who provides trauma-informed yoga training to schools and other organizations. We also do have a newsletter that is released every other month called Compassion Action. There will be a link to subscribe to that newsletter in the slideshow, and we have one coming out soon on compassion, fatigue, and burnout for schools. The Always and Now MHTTC School Mental Health Curriculum webinar series is continuing every other Tuesday at 1 p.m. Eastern. The next session is March 23rd, and we'll be talking about screening. There'll be a link to register for that event in the slideshow as well. For more information, please contact us at info@edimprovement.org or stay posted to the New England Mental Health Technology Transfer website and the CEI website edimprovement.org for links to our presentation and other slides. Thank you so much for being with us today.